Investigations of breast symptom. A patient presenting with any breast symptom is investigated by triple assessment. So what does this triple assessment include? It includes your clinical. So this clinical part includes your history taking and your clinical examination. Then your second part is your radiology. So this radiology part includes your ultrasonography and mammography. Then your third and the final part of your triple assessment is your pathology, which is your core biopsy. Please remember that nowadays the standard is core biopsy. Even your new edition of Bailey and Love, the 28th edition, has gone away with mentioning of your fine needle aspiration cytology. So the standard for your pathological diagnosis of your any breast tumor or a lump would be a core needle biopsy. Now let's understand a few important points with respect to your ultrasonography, mammography, core biopsy and few other investigations that are occasionally used in evaluating your breast disorders. So first, the ultrasonography. It is your primary imaging modality in your young woman with dense breast, where mammography may not give you the best results sometimes. It distinguishes your solid from cystic lesions. The simple cyst requires just a reassurance and a follow-up. You don't need to do anything for some simple cyst, but whereas cyst causing pain, you would be requiring a therapeutic aspiration. Then you would be getting some clinical scenarios or image based clinical scenarios, which are your well circumscribed mobile solid mass in young women. So this USG feature shows a well circumscribed and a solid mass, right? So this is your fibroadenoma. Whereas if there is a solid mass and then you have an irregular shape, right, and an ill-defined margin, this would be suspicious of your carcinoma. So you can see the difference of the benign and a malignant breast swelling in case of ultrasonography. Now the another advantage of your ultrasonography is that it helps in your axilla assessment, and where needed and a suspicious lymph node, it can go for a percutaneous guided biopsy from your lymph node. Right. Now the mammography. So this is a normal mammography which is shown over here. Your A is your mediolateral oblique view, and on the right hand side B is your craniocaudal view, right. So if you look at this image, so this is basically a normal mammogram, whereas now if you look at this image, on your image A, you find that there is this speculated mass, right. So a speculated mass arising. Then in image B, you see the tiny dots, right. I'll zoom in for you. So this tiny dot, so these are your fine pleomorphic calcifications, right. So fine pleomorphic calcification, and on your image C, you find over here that there is an architectural distortion, right, an architectural distortion. So these are your features which are suggestive of malignancy, right. Now there is a standard protocol of reporting on your ultrasonography and mammography imaging, which is your breast imaging reporting and data system, right? It is a universal reporting system used for breast disorder. So let's take a look at the various category. So we have your first category, which is category 0. So what happens over here is that the assessment is incomplete, right? The probability of malignancy would not be applicable because your assessment is incomplete and it would need for additional imaging evaluation and proper mammograms for comparison. Then you have your first category, which is your negative. So the probability of malignancy over here is essentially a 0%. Now the follow-up recommendation in category 1 includes your routine annual screening mammography for women over age 40 years. Then we have your benign findings. Again, the probability of malignancy lies 0%. Right, and you have your routine annual screening mammography for women over age 40 years. Then you have your probably benign findings, which is your category 3. Over here the risk lies between 0 to 2%. So the follow-up recommendation is your usually 6 months follow-up and examination. Right. So you need to know these categories because you might be getting a clinical scenario where they could be asking you regarding your category of the BI-RADS. Right. Then you have your category 4, which is your suspicious abnormality. Now this over here includes 4A, that is the findings needing intervention with the low suspicious or for malignancy, and the risk is over here 2 to 10%. Then we have 4B, which is your intermediate suspicious of malignancy, the risk being between 10 to 50%. And then you have 4C, findings of moderate concern with high suspicious of malignancy, the risk being 50 to 95%. Right. So over here you have your biopsy that should be considered. Then we have your category 5, which is highly suggestive of malignancy, and the risk over here is more than 95%, and it would require your biopsy or a surgical treatment. And in case of category 6, we know that it is a biopsy proven malignancy. So it is definitely a malignancy, and the category is reserved for lesions identified on imaging study with biopsy proof of malignancy prior to definite therapy. So over here definitely we know that it is a proven malignancy, so we have to treat this patients, right? So this is your standard reporting of your breast which is known as your breast imaging reporting and data system. Now there are some additional modalities of your imaging, which includes your magnetic resonance imaging and PET scan. So what are your conditions when you would be requiring to do a magnetic resonance imaging? So if you look at this image over here, so your A image is your pre-contrast image, and your B image is your post-ganglion contrast, and C is your subtraction image showing the presence of your breast tumor. So who are the candidates where you would want to do a magnetic resonance imaging? So women with dense breasts who have a discordant, right, a discordant or unequivocal findings on mammogram and ultrasonography. So the woman with dense breast or discordant or equivocal, right, equivocal findings on your mammogram and USG. Then MRI is used to distinguish scar from recurrence. Then your MRI has a role in assessing the multicentricity, multifocality of the tumor, right. So MRI has a role in assessing your multicentricity and the multifocality of the tumor, and in your high grade DCIS and lobular cancer. Then you also do MRI with BRCA, women with BRCA gene or any other genetic mutation, or any other genetic mutation, or even a strong family history. Then we do women with breast implants. Then women with breast implants also require MRI. So these are your few conditions where comes the role of your magnetic resonance imaging, right? Now another important modality is your positron emission tomography, right? So this is a staging investigation in patients with T3, T4, N2, N3 breast cancer, and in patients with T1, T2, N0, N1 in presence or symptoms or suggestive of metastasis. So the role of PET scan comes in T3, 4, N2, N3, or in NT or in T1, T2, N0, N1 only if there is suspicious of metastasis, right? And we may get some false positive results in case of mediastinal lymphadenopathy and pleuropulmonary lesion due to pleuropulmonary tuberculosis. So this has been a recent addition in your 28th edition of Bailey and Love. Now the last part of your triple assessment is your needle biopsy, and we do a core needle biopsy. Whenever possible, the best is to do it under image guidance, whether be an ultrasonography or a mammography. And then for core biopsy, we have a 14G gauge needle for your breast tissue and an 18G for your axillary tissue. So this is an image showing your core biopsy being taken from your breast lump. And now this core biopsy is mainly done for your IHC and your HPE status. Now the IHC is also the molecular classification. So on the basis of the IHC status, that is your hormone receptor status and the HER2 status, a molecular classification of the breast cancer has been developed, which is your luminal A. That is your hormone receptor positive, HER2 negative and Ki67 low. In case of luminal B, we have hormone receptor positive, negative HER2 new, but a high Ki67 index. In case of a basal type or a triple negative, it is a triple negative, so hormone receptor negative and HER2 negative and Ki67 is usually high. In case of HER2 enriched, we have a negative hormone receptors and a positive HER2 with the high Ki67. And then there is another entity which is your claudin low, that is your negative hormone receptor and a negative HER2 receptor with the low claudin content, right? So this is about your molecular classification of breast cancer. So these are your important points that you need to remember in your investigation of breast disease, which includes your triple assessment, clinical, radiological and pathological. Thank you.